Yes, so we are live now.
Right. So a very good evening to all of you, Honorable President of ASI, Dr. Praveen Suryavanshi, Honorable Vice President of the Royal College of Surgeons and Physicians of Glasgow, Mr. John, esteemed speakers, Professor Sadiq Sikora, Mr. Ewan Dixon, and presidents of the Sri Lankan College of Surgeons, who will be joining us later, President of Nepal, Dr. Romeo, President of the Bangladesh College, Professor Jamal, and the Honorable Health Minister of Malta, uh, Mr. Joe Abela, who is himself an upper GI and a HPB surgeon. My honorable office bearers of ASI, Secretary Dr. Gaddi, Treasurer Dr. Madhumita, supporting staff Dr. Jain, Dr. Avneet, Mr. Avneet, members of ASI, and members of the South Asian Society of Surgeons, where it is being transmitted all across the countries of India, Bangladesh, Sri Lanka, Malta, and Nepal. Welcome to the sixth joint webinar on biliary obstructions. To remind you all, we take topics of common interest to all, and we have been, which are encountered in our day-to-day practice, like breast diseases, coloproctology, and now biliary diseases. ASI really cherishes and values its bonding with the Royal College of Physicians and Surgeons of Glasgow and the association of many South Asian countries, especially Nepal and Sri Lanka, and would in future, of course, like to connect with other like-minded surgical colleges and associations across the world. Let us all join hands and work together in unison to raise the standards of surgical care and education. Today's talks cover a spectrum of malignant diseases which cause surgical obstructive jaundice. And we have two renowned speakers from two ends of this world, both master craftsmen in their field of work. After the talks, we will have a question and answer session, and I request all of you, all on board, to type your questions on the comment section of your YouTube channel, and we shall take them after the talks. Now, let us start, and I request the Vice President of the Royal College of Surgeons and Physicians of Glasgow, Mr. John Camillia Brennan, for his welcome address.
Thank you, Professor Nyogi. Good afternoon, ladies and gentlemen. It is a real pleasure to welcome you all to this afternoon's webinar, the sixth in our ongoing and highly successful series, jointly organized by the Association of Surgeons of India and the Royal College of Physicians and Surgeons of Glasgow. This collaborative initiative continues to thrive, built on a foundation of mutual respect, shared expertise, and a strong commitment to surgical excellence across borders. Today, we turn our focus to a particularly challenging and clinically significant topic, malignant biliary tree obstruction. As with previous sessions, this webinar promises to deliver insightful perspectives grounded in the latest evidence and real-world surgical experience. I would like to take a moment to warmly welcome the President of the Association of Surgeons of India, Dr. Praveen Suryavanshi, as well as Probal, the immediate past President of the Association of Surgeons of India, whose ongoing leadership and support have been instrumental in strengthening this partnership and in making this series a true success. A very special welcome also to our distinguished panel members who bring a wealth of knowledge and experience to the discussion. So we have Professor Kansakar, the President of the Society of Surgeons of Nepal, Professor Arya Ratne, who is the President of the College of Surgeons of Sri Lanka, Professor Jamal from the Bangladesh College of Physicians and Surgeons, and also Mr. Joe Abela, who is the Minister of Health of the Republic of Malta, and also a consultant upper GI and pancreatobiliary surgeon. And also my fellow surgical vice president, Mr. John Scott. Thank you all for being with us. And of course, it is a privilege to introduce our two keynote speakers, Professor Sikora, who is a director of hepatobiliary service at the Sakrawelt Hospital in Bangalore, and also Mr. Ewan Dixon, who is a consultant pancreatobiliary surgeon at Glasgow Royal Infirmary. We are honored to have you both with us, and we look forward to the knowledge and perspectives that you will share. With that, I will now hand over to Dr. Suryawanshi, President of Association of Surgeons of India. Thank you.
Thank you so much, John. So again, I welcome you all for this second session of this year, a joint webinar hosted by Association of Surgeons of India and the Royal College of Physicians and Surgeons, Glasgow. So thank you so much, Dr. Prabal, our immediate past president and convener international affairs, for hosting this joint webinar. And thank John also for joining us. And I'm really very happy and excited to attend this webinar because the topic which are selected, they are very interesting, and a lot of gray areas are there on the topics. So I'm sure both the speakers will share not only just their knowledge but their wisdom in managing these complex issues in HPB surgeries. And thank you so much, both the speaker, Dr. Ian Dixon and Dr. Sadiq Sikora, for accepting our invitation to be here this evening. And also I'm thankful to all our international friends from the Bangladesh, Sri Lanka, and Nepal. And special welcome to Dr. Joy Ebita for this webinar. So again, thanks to our advisor, Academic Council, Dr. Santosh John Abraham, for joining us. And again, big thanks to all the viewership. They are the one, they keep us going and keep the enthusiasm amongst us to host more and more such activities. So thank you so much. And over to you, Dr. Prabal.
Thank you, Praveen. And can I now request our Honorable Secretary, Dr. Gaddi Divakar, to introduce our first speaker, Dr. Sadiq Sikora.
Yes, sir. Good evening, everyone. It's my privilege to introduce Dr. Sadiq S. Sikora, who holds the degrees of MS, FACS, FRCS, Glasgow, and at present the Director of Surgical Services at the Institute of Digestive and Hepatobiliary Sciences, Sakra World Hospital, Bengaluru. Dr. Sikora completed his medical and surgical training at AIIMS, New Delhi, and a surgical oncology fellowship at the University of Pittsburgh, USA. He has held key academic and clinical positions at SGPG IMS Lucknow, Manipal Hospital, and Lakeshore Hospital, Kochi. He is a fellow of the American College of Surgeons and Royal College of Surgeons, Glasgow, and has served as president of the Indian Association of Surgical Gastroenterology and honorary secretary of the IHPBA Indian chapter. An acclaimed academician and author, Dr. Sikora has over 150 scientific publications and has authored the widely referenced Safe Cholecystectomy, an illustrated atlas. His key interests include safe cholecystectomy, bile duct injury repair, and pancreatic diseases. He continues to contribute actively through teaching, research, and his well-regarded podcast, Guts and Glory. To his credit, he has a lot of academic activities and achievements. He has been president of Indian Association of Surgical Gastroenterology for the year 22-23, honorary secretary of IHPBA Indian chapter 2013-17, and has been a reviewer of various indexed journals, including European Journal of Surgical Oncology, Journal of Gastroenterology and Hepatology, and is on the editorial board member of Journal of Gastroenterology and Hepatology, World Journal of Gastrointestinal Surgery, and various other international and national journals. He is the member of International Task Force to formulate consensus guidelines for preventing bile duct injury. He has various memberships of the societies spread all across the world. We are honored to have him with us today. This is Dr. Sadiq Sikora for you. Thank you.
Dr. Professor Sadiq, for your talk, please. Thank you. Sadiq, you are muted.
Let me share my screen. So, can you see my screen?
Yes, yes.
Yes, we can, sir. Please.
Thank you very much. It's indeed an honor and privilege to be invited for this joint webinar. And I'm really thankful for this invitation to Prabal. Thank you to Dr. Suryavanshi and Dr. Divakar. And of course, many thanks to Mr. John Brennan for hosting this webinar and letting me be part of this. I'm quite delighted with this. The task given to me is carcinoma, gallbladder, and jaundice, what to do. I think it's a very challenging area with a lot of gray areas, which I hope to cover and do justice to in the next few minutes. We all realize that gallbladder cancer is endemic in certain regions of India, and particularly the northeastern belt and the Indo-Gangetic belt. It is one of the commonest biliary malignancy. Nevertheless, jaundice at presentation generally suggests a locally advanced disease with poor outcome. We all understand that curative option available for gallbladder cancer is surgery, but is best accomplished in early disease. And patients with jaundice are surrogate markers for advanced disease. There is some hope on the horizon with multimodality treatment and improvement in surgical techniques. And let us see what that hope brings to these patients. This article posed a very pertinent question, that is gallbladder cancer presenting with jaundice uniformly fatal or still potentially curable? And that is the crux of the discussion today. In this American review of gallbladder cancer, only 1/3 patients with gallbladder cancer presented with jaundice. Only a third underwent resection with curative intent, and they had a very high morbidity, reoperation rate, and a low overall median survival of 14 months compared to the non-jaundice patients. This is a systematic review and meta-analysis of outcomes of patients with surgical resection of gallbladder cancer with jaundice. And it is clear that jaundice group had higher postoperative morbidity, bile leak, post-hepatectomy failure, and had overall reduced survival, suggesting that it is a very poor outcome for these patients. And generally, it encourages a nihilistic attitude towards this group of patients with a dismal disease. But let's look at gallbladder cancer and jaundice. So the common reason for jaundice in these patients is direct tumor infiltration into the hilum, into the hepatoduodenal ligament, or they could be extensive nodal disease compressing the bile duct. And these are the common scenarios wherein gallbladder cancer and jaundice are associated. But we should not forget there are a myriad other causes of jaundice in patients with gallbladder cancer. Since stone disease is commonly associated with gallbladder cancer, bile duct stones may be present incidentally or causing jaundice. There could be a xanthogranulomatous cholecystitis with biliary stricture, or recurrent inflammation due to stone disease leading to stricture formation. In east part of the world, abnormal pancreaticobiliary ductal union associated with choledochal cyst and gallbladder cancer is common, and the cause of jaundice could be related to the choledochal cyst rather than the cancer. So we need to remember that gallbladder cancer with jaundice also comes in other colors, and we need to ensure that we do not miss the treatable cause and just label these patients as a dismal outcome because of the jaundice. So this patient presented with jaundice, pain, abdomen. We had a thorough evaluation with ultrasound, CT, ERCP. You can see that there's a mass in the gallbladder with the indistinct margins with the liver and a stone present there. Despite all our efforts, as the diagnosis was not established, we took this patient up for laparotomy. The colon was adherent, and on dissection, we realized that the findings were very typical of a xanthogranulomatous cholecystitis. And eventually we were able to do a subtotal cholecystectomy, and the pathology revealed xanthogranulomatous cholecystitis with no evidence of malignancy. Why I raise this issue is it's a XGC or xanthogranulomatous cholecystitis is often masquerades as gallbladder cancer. And there is a lot of literature available, it mimicking gallbladder cancer and difficult to differentiate with gallbladder cancer. And this benign disease should not be missed or labeled as gallbladder cancer. We tried to define whether there are any characteristic clinical findings for suggesting the presence of gallbladder cancer. And we came up with anorexia, weight loss, jaundice, and palpable lump in XGC with gallbladder cancer. So this could be some markers towards associated gallbladder cancer. This is a beautiful paper from Tata Memorial Hospital in India, which specifically looked at 100 cases of obstructive jaundice. And what I want to bring to your notice at this point is 30% of patients in this series had benign causes of jaundice. So that is important to remember. For example, this patient with choledochal cysts, as you can see here on CT and ERCP, had gallbladder cancer and a choledochal cyst which did not have any infiltration with malignancy, and patient underwent extended cholecystectomy with bile duct resection and a hepaticojejunostomy. Once we have these patients with jaundice, they do undergo a very extensive workup, a complete blood workup, tumor markers, specifically CA19-9. I find that MRI with MRCP is a very useful cross-sectional imaging to determine the extent of liver infiltration and the ductal anatomy, especially in patients with jaundice. These locally advanced diseases or gallbladder cancer, they invariably get a PET CT in our practice, and we often combine it with a contrast enhanced CT scan to assess the vascular invasion, if any, in these patients. We realize that these patients, if they are planned for surgery, need to be thoroughly evaluated since they would be elderly and may have associated comorbidities. So these are some series of images of advanced gallbladder cancer with artery involvement and portal vein involvement. Clearly, this is unresectable disease. This is a very typical imaging findings of patients with gallbladder cancer. You can see in CT scan enhancing mass in the neck of the gallbladder, dilated bile ducts on MR scan, and a lesion seen in the neck of the gallbladder, and several regional lymph nodes, which I would characterize this patient as a borderline resectable gallbladder cancer. And on the other end of the spectrum, this is a patient on MRCP having an infiltration isolated into the bile duct, causing obstruction, a PET CT showing uptake in the liver and in the region of the infiltration in the gallbladder. And perhaps this is one of those which is resectable. So we need to go through the drill, ABC, anatomy, biology, and condition of the patient. And we look at liver infiltration, hepatoduodenal ligament infiltration, bile duct, and adjacent organ involvement, because they all have a role to play in terms of the plan which we have for these patients. The best available methods of assessing the biology at present is a raised CA19-9, which is, if it is higher than perhaps 1000 or so in patients with jaundice, then it indicates an advanced disease and even a metastatic disease. An extensive nodal disease, we all realize, has a poor harbinger of outcome in gallbladder cancers. The condition of patient is also important. They are elderly. We need to pay attention to their comorbidities, pulmonary reserve, and if they have cholangitis, coagulopathy, that needs to be treated and corrected. So once we make an assessment of ABC, the patients may be categorized into resectable, unresectable, metastatic, or borderline resectable. And a word about borderline resectable. This has been a term which has been coined in gallbladder cancer also, akin to a pancreatic cancer. And this represents a locally advanced disease in T3, T4 tumor, nodal disease, vascular involvement, and in our case, we are interested in the bile duct infiltration. The Tata Memorial Group, which has published this paper, has suggested that the best course for these patients is to offer neoadjuvant chemotherapy. And what they found is, as far as operability is concerned, stage of disease, CA19-9 levels, and liver infiltration predict operability, and the higher the stage and level of CA19-9, the lower the resectability in these patients. As far as if they complete the neoadjuvant therapy and resection, then stage of disease is the only factor which predicts overall survival. The preoperative preparation is also important in these patients. Prehabilitation is critical to look at their nutrition, their pulmonary reserve, and overall general well-being, and correct all the coagulopathy infection as I mentioned earlier. Patients with gallbladder cancer and jaundice may require specific interventions preoperatively. They may need biliary drainage, which could be accomplished by an endoscopic method or a percutaneous drainage, because most of these will need neoadjuvant chemotherapy. And if these patients are planned for major liver resections, as I will show, then we need to address the future liver remnant to be adequate by using portal vein embolization. So a lot of preoperative protocols are required to manage patients with gallbladder cancer and jaundice. What about the extent of surgery? Either it could be a segment 4B5 resection with extrahepatic bile duct and regional lymphadenectomy, and you may end up with 2 or 3 bile duct openings which you need to join with a Roux-en-Y hepatocogenostomy. These procedures are tolerated well by the patients, and the morbidity and mortality is acceptable. On the other hand, if they need a large liver resection, like a trisectionectomy or a modified right trisectionectomy, which is 4B with right hepatectomy, or a central hepatectomy, then they need extensive preparation. As I mentioned, biliary drainage, portal vein embolization, and generally they have a very high morbidity and mortality. Occasionally, pancreaticoduodenectomy may also be required along with extended cholecystectomy in these patients. And there are very specific indications. I'll come to that. If there are adjacent organ involvement like stomach and colon, these could be resected in selected patients. Again, selection of patients is important. Outcome is generally bad, especially if there are multiple organs involved. For example, if you need to do a pancreaticoduodenectomy, what are the best indications for that? And this very nice paper in 2024 suggested that if the mode of spread is either direct into the peripancreatic tissues or due to the lymph nodes individually, we could achieve good R0 rates and a reasonably good 5-year survival. But if both of these modes of spread are present, then perhaps it is not appropriate to offer these patients pancreaticoduodenectomy. And finally, a word about hepatopancreaticoduodenectomy, the Cadillac operation, and whether it should be done for patients with gallbladder cancer and jaundice or not. And this is a meta-analysis, a systematic review of 13 series, and you can see uniformly very high morbidity is associated with that, with almost mortality running up to 30 to 35%, barring some Japanese series recently published, which have shown single-digit mortality in this procedure. So basically, it is a very complex surgical undertaking to be taken up for these patients, and it could be offered to a very select group of patients remembering that it is associated with high morbidity and mortality and should be performed only at very skilled centers who are routinely doing these procedures. Just a representative case, a large tumor underwent portal vein embolization, neoadjuvant chemotherapy, and you can see after that hypertrophy of the left lobe. And eventually, this patient underwent a trisectionectomy with R0 resection, and patient is on Apollo. Of course, we can undertake these procedures, but these are far and few, and a diligent selection of patients is very critical. This paper I like really very much because it gives a very good idea about the status of gallbladder cancer with jaundice as they've experienced over 10 years of 113 cases. Out of 1,000 patients, almost 10% had jaundice, 30% had benign cause of jaundice, and resectability rate was 62%. What is interesting to note is about 75% of patients either had benign causes of jaundice or isolated bile duct infiltration, and this has a bearing on the outcome. Biliary drainage was required in 95% of patients, majority by endoscopic means, and about 50% had neoadjuvant chemotherapy. And the outcome results are quite encouraging. If you look at the overall cohort, 22 months median survival. If curative resection is undertaken, then it's 32 months median survival. And if, interestingly, if the bile duct infiltration is isolated and only to the bile duct, no lymph node disease, the overall median survival is a whopping 74 months. So there is hope for patients with jaundice, albeit in very selected group of patients. So in conclusion, my messages are jaundice is not always a futile situation in gallbladder cancer, and we must look very closely to rule out benign associated causes of jaundice. Of course, if it is extensive infiltration into the hepatoduodenal ligament, it is associated with poor short and long-term outcomes. But in selected patients with multimodality approach requiring biliary drainage, neoadjuvant chemotherapy, and portal vein embolization as protocol, these patients could have extended resection with perhaps good outcome, and that remains to be seen. Finally, I just want to let people know that there is a lot of podcasts on gallbladder cancer, an incidental gallbladder cancer, and if anyone is interested, can log into this channel. Thank you very much for your patient hearing.
Thank you, Professor Sadiq, for an excellent lecture. And it was really from a hopeless situation, you have given some hope, and probably there's some light at the end of the tunnel. Thank you very much for your excellent talk. Can I now ask Mr. John Camelia Brennan to introduce our next speaker, Dr. Ewan Dixon.
Thank you. It is my great pleasure to introduce our next speaker, Mr. Ewan Dixon. Mr. Dixon is a consultant biliary and pancreatic surgeon and leads the regional referral unit for complex pancreatic and biliary surgery at Glasgow Royal Infirmary. He also has a strong interest in emergency care, and after gaining an MD, he undertook a trauma and critical care fellowship at Johannesburg General Hospital. He was awarded the Association of Surgeons of Great Britain and Ireland Medal as the outstanding candidate in the final sitting of the FRCS intercollegiate exam, prior to his appointment to the West of Scotland Pancreatic Unit in 2007. His subspecialty practice includes major pancreatic resections, the management of severe acute pancreatitis, and advanced pancreatobiliary endoscopy, including ERCP and endoscopic ultrasound. In 2019, he was awarded the James de Fort Association of Surgeons Traveling Fellowship, one of the most prestigious international awards for surgeons. The primary focus of this fellowship was in the management of borderline resectable pancreatic cancer. His academic, teaching, and research interests are in pancreatic surgery, trauma, enhanced recovery after surgery, and perioperative care. He has lectured and taught extensively in these fields and continues to publish and author book chapters on these subjects. He is the national lead for hepatobiliary surgery and lead clinician for surgical critical care and pancreatic enhanced recovery after surgery program. Mr. Dixon.
John, thank you very much for the kind invitation. Can I just check that you can see my screen and hear me okay? Yeah, great. So thanks to John, but thanks also to the ASI and the Glasgow College for the kind invite. I really enjoyed the session we did previously on benign biliary disease. When my wife asked what I was speaking about today and I told her I was doing this, she said, "That's really surprising, they've invited you back." So thanks to Sarah for the ego boost. My background, as John said, is I work in the West of Scotland HPB unit, a tertiary referral centre serving Glasgow and the surrounding area. My elective practice is exclusively pancreatic and biliary work, excuse me. And that means we undertake all the major resectional surgery for the region, including Whipple resections or distals. We manage the complex benign disease, including severe acute pancreatitis and chronic pancreatitis. And I also do advanced pancreatic endoscopy, including ERCP and EUS. So the key points to consider when we're looking at what not to do for the patient with periampullary malignancy, or PAM. The first thing is you might not know this is malignant at presentation. In fact, usually you don't know it's malignant at presentation, so always bear that in mind while you're making your decisions. The second thing is that you may have to guide the patient towards a decision without ever knowing whether the lesion is malignant or not. If you have a negative brush cytology or negative EUS-FNB, you then have a dilemma where you may suspect malignancy but not actually be sure it's malignant. EUS and ERCP are without question the final common pathway, I think, for many patients with suspected periampullary malignancy. And the problem with that is that both of these modalities carry risk, both in terms of morbidity and mortality. So if I could start with one take-home message from this talk, if there's nothing else you remember from this talk, it's this. I think in the initial phase of managing the patient with periampullary malignancy, it's very easy to get things wrong. So don't do anything until you've thought through all the options for the patient, particularly with regards to concepts such as preoperative drainage and so on. Don't do anything until you've thought everything through. And that takes me on to the key question, to drain or not to drain. Now, this is the most common question that we are asked in the HPB unit, whether to proceed to biliary drainage or not, perhaps from one of the regional or the local referral hospitals. There are several options for biliary drainage, including ERCP and PTC, which are probably the two most commonly used. And then there are newer modalities which we are currently employing, including EUS bile duct drainage into the duodenum and occasionally left duct drainages into the stomach. But given the target audience for this symposium, my talk's going to focus mainly on ERCP for several reasons. One, it's the most common modality we use for periampullary malignancy or suspected malignancy. Two, it's widely available out with all the tertiary referral centres. And therefore, the ERCP option or decision-making is the one that affects most of us, even if we're not HPB specialists. So my starting point for ERCP and suspected periampullary malignancy is there are too many ERCPists doing too many ERCPs in patients with potentially resectable periampullary disease. And so while it might seem like a great idea just to go ahead and drain a patient who's jaundiced, it's not always the right thing to do. So the first question you have to ask yourself is, what is the role of ERCP in periampullary malignancy? And this goes back to the title of the talk, which is what not to do. So firstly, you have to define the problem. So periampullary malignancy can take on a range of different pathologies, but for the purposes of decision-making and this talk, I tend to split it into four big groups: PDAC or pancreatic cancer, bile duct cancer, genuine or true ampullary cancer, and then duodenal cancer. Now, clearly there are other things such as NETs and so on, but for the purposes of this talk, these are the big four, which I'm going to group together to try and illustrate our approach and what not to do. So the role of ERCP is well established for dealing with jaundice patients with periampullary malignancy, and it's readily accessible in most hospitals, which is the reason for discussing this element today. It has two elements to it. There's the diagnostic element, usually with brush cytology, and then there's a therapeutic element, for example, placing a biliary stem, such as you see here, to achieve biliary drainage. And so this should be really, really easy for all of us because we're only trying to answer one binary question. Should I ERC this patient? So why do we struggle with this? All we're trying to work out is whether we do an ERCP or not. And the reason we struggle is because there's a large volume of data points, all coming at you in different directions, all perhaps mutually incompatible, all leading you down a different treatment trajectory. And your job is to try and synthesize all these data points, not just a jaundice patient, but all these data points. And once you've synthesized these data points, try and come to a conclusion which is ERCP, yes or no, because there's no maybe involved. It's a very binary decision. And I think that's why we struggle. So when you start to synthesize all these data points, for example, patient age, comorbidity, metastatic disease, tumor size, and so on, you're trying to make the best ERCP decision you can in the absence of certainty. So you have to look at what happens if you get that decision wrong. So say you have a patient in front of you and the correct answer was yes, you should drain this patient. And say you decide not to drain them or you delay draining this patient. Then the unintended consequence is delayed biliary drainage, and that's probably fixable. So to summarize, if the correct answer was yes, drain them, you choose not to or you defer drainage, the worst that usually happens is delayed drainage, and that's something you can probably get yourself and the patient back out of. Then you have to contrast that with, say the correct answer was no, don't drain this patient, that's not the right thing to do. But you go ahead and arrange an ERCP or you drain this patient. The unintended consequence here is that you may convert an operable patient into an inoperable patient, and that's an absolute catastrophe. And the reason I put this slide up is that we all know that we make decisions in the absence of certainty. You're making decisions in a relative information vacuum. If we had a crystal ball, it would be very easy to make the decision. And the reason for portraying these two worst outcomes is to make the point, if you're unsure, or even if you think you are sure, there may be a place for deferring drainage until you've thought everything through, because you can get yourself and the patient back out of that way more easily than you can if you've created a perforation or caused pancreatitis or had an ERCP mortality. And again, I mentioned this in the previous talk I gave to this symposium. When you're a surgeon or an endoscopist or a proceduralist, it's very easy to have your judgment clouded because the whole world starts to look like a nail when all you have is a hammer. And it's easy to practice procedure-focused medicine. And I think one of the strengths of the Glasgow unit is because as surgeons we do the workup, the EUS, the ERCP, we run the MDT, we do the operating, we do the palliative bypasses, we had the clinic discussions. Because we do the full breadth and spectrum of pancreatology, it's easier, I think, to sometimes choose the correct procedure, which isn't to say we don't get it wrong, we do, but I think that makes it easier being able to control every element of the practice. And when it comes to decision-making for periampullary malignancy, there are two parts to it. There's decision-making, then there's a practical skill of ERCP drainage, and for sure the hardest thing is decision-making. And that's because the patient with jaundice and periampullary cancer is on a journey where there's going to be a spectrum of disease punctuated by critical decision nodes. And at every decision node, you have to get that decision right. And so you're working out whether you intervene, yes or no. If you do intervene, how do you do that? Is that PTC or ERCP? And a lot of these decisions, I think, come through pattern recognition, algorithms, experience of working in a relatively high volume unit, having seen your colleagues to ask questions of in terms of your decision making. And the key is really to get all of your ducks in a row. So if you have a patient in front of you, if you're the on-call surgeon, or if you're working in a tertiary referral practice, you want to collect and synthesize all the necessary data points that allow you to make a decision for this patient. I would suggest the default position is not to ERCP until proven otherwise. Now, many of these patients will have an ERCP ultimately, but go back to my previous slide, If you delay ERCP, you can usually get out of that. If you do an unnecessary ERCP, it can be very difficult to get yourself and the patient back out of that. And again, recognising many of these things are institution dependent and clinician dependent, so you can't really claim to have a monopoly on the right way of doing anything. But in Glasgow, this is the way we try and pass go and collect £200 on the way. To understand the very tip of the pyramid of decision making, you have to work your way through all the factors at the bottom. So what are the factors, patient, radiology, clinical, bloods, that take you in the right decision as to what to do with this patient? So our approach is to firstly work out, is the lesion potentially resectable? And remember, as surgeons, we get very focused on the technical resectability, but that's not what I mean by resectable, because most things are resectable. The question is, should you resect? And when it comes to should you resect, in terms of potentially resectable, there are what I consider the two P's of surgical decision making. There's the patient and there's the pathology. And it's probably in that order. And so when it comes to patient factors, what about fitness for major resection? There are objective ways of looking at that, such as CPET to measure the anaerobic threshold or the patient's metabolic equivalence, or FEV1. And then there are the subjective things, so the patient comorbidity, the performance status. And actually, what we do in Glasgow is what we call the meerkat test, and that's where you invite the patient to clinic, and all the surgeons are in the rooms in the corridor, and the patient walks up the corridor, and everyone sticks their head out like a meerkat to watch the patient walking up. And that often tells you a lot more about suitability for major resection than any of the objective measures you have here. If the patient's attending with a walking stick, or they're frail, or they seem slightly short of breath, all the surgeons pop their head out, have a look at the patient walking up. The meerkat test is probably the most sensitive way of working out whether someone's suitable for a major resection or not. So these are the subjective and objective patient factors to determine resectability. When it comes to the second P, that's the pathology factors, this is usually answered by cross-sectional imaging, usually CT, chest, abdomen, pelvis, plus or minus EUS. And reasons for irresectability would be technical issues, such as the top slide here, where you can see clot in the portal vein, or other vascular issues for which there's not a reconstruction option. And then there are the distant factors, the non-local factors. That'll be factors such as metastatic disease or ascites that render the patient irresectable. And why is it so important to put resectability into a little box at the start? Going back to an earlier point, the hardest thing in life and in surgery is making a decision. If you tell someone to operate, most people can operate, but deciding to operate and patient factor decision-making at the start can be a real challenge. And the reason for deciding whether someone's resectable or not in terms of comorbidity and the lesion itself is it forces us to put the patient onto one end of the spectrum, either for surgery or for palliation. It commits us to dichotomize and make a decision. And so if we think a patient's suitable for surgery, we tend to split those 4 tumours at the start I told you about. That's pancreatic cancer, bile duct cancer, duodenal cancer, and biliary cancer. We split those 4 big groups into 2 because it makes it easier to make a decision. It's either a pancreatic cancer or it's not, so PDAC or not. And the reason we split into these 2 groups is this absolutely informs our decision-making and our management algorithm. And so if the patient is resectable and it's a pancreatic cancer, we think, they have an EUS for FNB, they have an ERCP at the same sitting for a stent, and then they tend to go down a neoadjuvant pathway, almost irrespective of the resectability factors. If it's a non-PDAC patient, that's bile duct and biliary or duodenal cancer, we quite often do an EUS, not always with a biopsy. If you see a small mass in the bile duct with obstructive jaundice and you go to do an FNB of that, you can cause pancreatitis. So an EUS, with or without biopsy, not for ERCP, and usually for early resection. For the patient who you've put at the palliative end of the spectrum, either through patient factors, comorbidity, or tumour factors such as irresectability, then these patients are all put into the peri-and-biliary group. There's no need to distinguish between PDAC and non-PDAC, and they will almost always have an ERCP plus or minus EUS for tissue. takes me on to the next point. The reason we split it into PDAC and non-PDAC periampullary malignancy is that we manage them differently. The non-PDACs get an upfront resection if possible, and the PDAC patients are offered neoadjuvant therapy. We know that patients get the best outcome with pancreatic cancer if they complete multimodal therapy. In our experience, about 50% of our surgical patients went on to complete adjuvant therapy, so half or less. And so in our experience, the best chance of completing chemotherapy is if they have chemo first, then surgery. Unlike when I started, we now have reasonably effective chemotherapy. When I started, it was all gemcitabine. Now we have FOLFIRINOX or gemabraxine combinations. And our initial experience of using the upfront chemo approach has been pretty good in terms of radiological, clinical, and pathological response. And if nothing else, I think the test of time and oncology often avoids a Whipple patient who already had occult metastatic disease, which then declares itself 3 months after a major resection. So at the other end of the spectrum, not the PDAC, but the non-PDAC patient, that's bile duct, ampullary, and duodenal cancer, who comes in jaundice, you want to operate on them up front if you can. So why do you do that? Why not go directly to ERCP? Mainly because you want to avoid the avoidable complication of biliary drainage. And it's all about a balance of risk. There's the morbidity from the drainage versus the morbidity of operating in the context of jaundice. So we've got a pretty good evidence base for this over the last 15 years or more, with in particular the DROP trial, where they quite clearly demonstrated a reduction in the risk of complications by avoiding preoperative drainage before a Whipple resection. There were some limitations to that study. I think they excluded patients with a bilirubin of greater than 250. So we have our own series of about 30 or 40 patients back at that time, so a contemporaneous study. The super jaundice patient who had a bilirubin of 250 to 500, so up to twice what they had in the DROP study. And we found no difference in surgical outcome operating on the super jaundice patients when you compared it to the pre-op biliary drainage group or the undrained bilirubin less than 250, other than a transient fall in their EGFR at day 3, which responded to fluids. And the way to manage the super jaundice patient for upfront resection is good hydration pre-op. Don't do the operation if they're starting to get synthetic issues, so their albumin's falling, their coags becoming deranged. And unlike when I usually do a Whipple in the super jaundice or the jaundice patients, excuse me, who are having upfront resection, I would divide the common hepatic duct almost at the start of the operation to try and allow some biliary decompression. So most of this talk, I've said, try to avoid ERCP if you're going to operate on the patient. But are there any exceptions to that? And of course, things are never quite as binary or as black and white as we portray them in these presentations. And we always have to remember that host physiology always trumps anatomy. So if the patient's not fit for immediate resection and they have suspected periampullary malignancy, that's either because of cholangitis or because they've got comorbidity, which means they may never be resectable. Either way, in this group, we would go to ERCP early. So here's the exception to everything else I've been saying. The sick patient with cholangitis or the unfit or comorbid patient, ERCP and stent. If you try to ERCP and stent the cholangitic patient and you achieve success, you get biliary drainage and everything settles, surgery when they're fit, usually a few weeks later. If you fail the ERCP, and that's not uncommon, then your options are resuscitate, intravenous antibiotics, and then either try again with PTC or think about early operation. But usually if they've had cholangitis, we'd go down the route of PTC. First of all, even just leaving an external biliary catheter in to let the sepsis settle before you think about an operation. So we've almost synthesized all our data points, the 2 Ps of patient and pathology. If you are stenting, I think we've broken it into 2 groups. If it's a resectable PDAC, they come to our unit for a combined EUS. If it's irresectable or it's a periampullary cancer, no matter what it is, they get ERCP'd in the base hospital. If you are going to stent, I do wire-guided cannulation. I do limited contrast, not under pressure. I do a sphincterotomy to try and avoid obstructive pancreatitis from the SEMS. I do brush cytology. We give Voltarol to try and reduce the chance of pancreatitis. It's all risk mitigation. Remember, when you are placing a stent in these patients, pigtail stents are only for stones, they're not for strictures. Straight plastics I tend to use for post-lap chole bile leaks, and I use a partially covered SEMS for all the cancer patients. They're more durable I think they have longer patency rates, and I use the partially covered because there's a little bit of bare metal at either end that helps prevent stent migration. When we're doing a combined EUS ERCP, we can do an EUS FNA for core at the same time. EUS post-stenting can be more of a challenge, so we try and do the EUS then the ERCP if it's the same sitting, mainly because you get stent artifact. We've got a rapid access system in Glasgow. We view periampillary cancer as an oncological emergency as much as we can. And we have a very clear algorithm in terms of a pathway for imaging, endoscopy, CNS input, nutrition, and so on. So we've covered the algorithm. If it's PDAC, you do a CT scan, resectable, rapid access, endoscopy, neoadjuvant Whipple, irresectable, they get an ERCP in the base hospital. The non-PDAC patient, bile duct duodenum ampulla, if it's resectable, they come to us, usually for an EUS to confirm what we think and exclude a stone, for example, then get a resection, irresectable ERCP in the base hospital. Remember, I think if nothing else, this is about teamwork, early discussion with the regional centre, don't stent or drain until you've had a chat. Only about 10 to 15% of our patients in the West of Scotland ever come to resection, so ERCP is usually required, but preferably after discussion. So my last slide, take-home messages. Potential resectability is your first critical decision node for suspected periampillary malignancy. CT cap is the imaging modality of choice. Resectability isn't just what you can do with the diathermy, it's a function of two Ps, patient factors, pathology factors. A resectable PDAC gets an EUS ERCB as a combined procedure, plus neoadjuvant if appropriate. The resectable non-pancreas cancer gets EUS and urgent workup for surgery if they're fit. Most of our patients have irresectable disease either through local factors, metastatic disease, or patient factors. So 80 or 90% of our patients are still getting ERCP after discussion. It's very, very easy to render an operable patient irresectable with an ERCP. And so the take-home message again from all of this talk is think before you drain and make sure you have a discussion with the regional unit in advance, the exception being the very unfit patient or the patient with cholangitis. Thank you very much for your time.
Thank you, Ewan, for a very informative talk. You have put it's so much easier when you are working in a unit where you're taking care of both endoscopy and the surgical part. So I think that is the best place to go because you can take the decisions in a very fair manner and without any bias. Thank you very much, Ewan.
Thank you.
We can put up the questions now and I welcome the Sri Lankan President, Professor Duminda Aryate, who's just joined us. I can see him on screen. Good afternoon, good evening, Duminda. We will take up some questions now. Yeah. Any comments from any of the panelists, or shall we go to the questions first?
Questions.
We'll take the questions. Now, as expected, there are a lot of questions for Sadiq because CA gallbladder is a very common condition, especially in North India. And it's one of the commonest, one of the high endemic areas in the world. So, Sadiq, one question from Dr. Nikita is that when should we operate on an incidentally detected CAGB? Is there any time frame that should be followed? Once you detect an incidental GB on a pathology, is there a time frame to follow? And what do you do? What should you do?
Yeah, so this is a little out of the topic that
yes, it is.
Nonetheless, see, when you detect an incidental gallbladder cancer, a truly incidental is when you get the pathology after a cholecystectomy and it is not suspected during cholecystectomy also. In that event, as soon as you start discussion with the patient regarding resurgery or a completion cholecystectomy, which we would recommend in this situation. The time frame is very nebulous. And there is some data which is coming up from several Indian publications and from Tata Memorial Hospital that if you wait for 6 to 8 weeks, that may be the best time to operate in this patient, because if there is uh, evidence of dissemination or advanced disease, it would present itself. But I think that's not a very practical approach. So most of the time, we would offer these patients resurgery uh, once the pathology report is available to us. And at resurgery, we would do a completion extended cholecystectomy, which is taking a wedge of the liver of 2 centimeter and clearing the hepatoduodenal ligament and hepatic artery nodes with an extended lymphadenectomy.
Right. Thank you. So I think the next question to you is in a probably he means Biplab Pal asks probably this means irresectable gallbladder cancer with jaundice, tenting or PTBD, and what are the indications?
So both for even resectable or one which can be resected but need major liver resection or a neoadjuvant chemotherapy, we would do a preoperative biliary drainage. So these patients, now the mode of drainage will depend on the anatomy. If it is a common hepatic duct occlusion or the main bile duct occlusion due to either lymph node compression or due to direct infiltration from the neck of the gallbladder, then most of the time endoscopic stenting would be appropriate, feasible, and is preferred. If it is a high obstruction with most ductal systems separated, their endoscopic drainage is often not feasible, and therein we would prefer doing a percutaneous transhepatic drainage to the lobe which is going to be preserved or the future liver remnant in case surgery is being planned. If it is a palliative stenting, then again, depending on the level of block, you would want to do a stenting either endoscopic or percutaneous. And in palliative stenting, it is often preferred to do a endoscopic stenting because you really don't want to drain all the ductal system, but a main duct system, if you drain, it should be enough in the absence of cholangitis as part of palliation.
Okay, right. Uh, so stenting, you would still stent even if it's operable CAGB. Is that what you
So,
meant
so operable CAGB with jaundice
with
is
John?
entirely a different cup of tea as opposed to what Ian was talking about. And here, these patients have locally advanced disease. The current mantra is to do multimodality treatment. That means neoadjuvant chemotherapy. And if we have to do neoadjuvant chemotherapy, they need to have a bilirubin below 3 milligram percent. So that means they need stenting. So yes, most
Okay,
patients will require
okay, yeah.
stenting.
This is a question from Sumit Chaudhary. Uh, how common is jaundice in gallbladder carcinoma due to other causes? So, what he means is that in a case of CA gallbladder, how common is jaundice because of the CA gallbladder, not because of other causes?
Yes, I think it's an important thing to consider, keep in mind, and always evaluate. As I showed in one of the large series,
Yes.
30% of these patients had benign causes of jaundice in association with gallbladder cancer. And in most other experience, it would vary from 10 to 30% as other causes of jaundice. Most common being stone disease. That would be the most common cause. So yes, it is not very uncommon, and we need to look for these causes which would make the outcome entirely different, because jaundice due to gallbladder cancer versus a benign jaundice has different connotations, both in respect to how you approach these patients and what treatment strategy you adopt for these patients.
Right. For even this question, is there a level of bilirubin that needs drainage before surgery and level at which surgery can be offered?
Good question. The short answer is no. There's not really a level that would push you one way or another. It really comes down to synthesizing all the data points. So say you had a bilirubin of 250 in a 75-year-old with a bit of ischemic heart disease, a bit of obesity, some other factors. That's a patient in whom you might think about draining first. But that same level of bilirubin 250 in a 40-year-old who's fit with an ampullary cancer will not impact your decision making as long as there's no evidence of biliary sepsis. That's the first thing. And the second thing is no evidence of synthetic dysfunction. So we would regard a falling albumin and a coagulopathy that was starting to drift as relative contraindications. So there isn't a bilirubin absolute value that would stop you. It's all contextual, as most things are in medicine.
Yeah, there's some institutes have a protocol that they above a level of 15. I do not know it's in the international units, milligram per deciliter. There are some institutes that have a protocol that if you go beyond 15, you 10. Sadiq, what do you say? You worked in many institutes, in All India Institute and in the SGPGI. Do you have a level for which preoperative stenting should be done?
No, as a matter of fact, I entirely agree with what Ewan is saying, especially for periampullary tumors. So it'll all depend on basically, as he has emphasized very clearly, the patient condition and associated sepsis. That is the only reason, because we've published, and there are many publications which talk about the downside of stenting in this, as he has also highlighted in his talk, and predominantly sepsis being a problem and other complications due to ERCP.
Right, Sadiq, next question. What exactly about obstructive jaundice in carcinoma gallbladder increases mortality and indicates poor prognosis, which is not there in non-carcinoma GB causes of obstructive jaundice?
So most importantly, it is the whole scenario. So these are advanced diseases in patients who are elderly, may have comorbidities, they are poor nutritionally, and these patients may need major resections. And most of the morbidity in these patients is due to the major hepatectomies leading to post-hepatectomy liver failure or bile leaks. So it is again, I think the stage has been set by the ABC, and what also Eon emphasized, that it's not only the anatomy, it's the patient condition. And here with the advanced malignancy, these patients are not in the best shape. And if they need extended resections or major resections, they don't do very well. And that's the problem in this group of patients.
Right. Even one question for you. Now, this is a scenario that this gentleman gives, Dr. Yusuf. My question is, in periampullary carcinoma with duodenal obstruction, CT showing no enlarged lymph nodes, but with raised bilirubin, what will be the management option?
Yes, so that's a great question because that highlights dual obstruction. Most of the patients we've spoken about up until now have one obstruction, that's biliary obstruction. And there are different ways of approaching that, PTC, ERCP, and so on. What your delegate's probably describing is it's usually a duodenal cancer. You rarely get duodenal obstruction from an early cholangio or ampullary. But the duodenal and biliary obstruction combined is a real problem for one reason. It's really difficult to try and overcome both of those and keep the patient resectable. So it's going to come down to, do you think the patient's resectable? In the patient with dual obstruction, so duodenum and biliary, and they're fit for an operation and they've not got synthetic dysfunction and there's no metastatic disease, we would try to resect that patient early if we could. If the patient's never going to be fit for an operation, then your options are duodenal stenting or gastrogedge. we tend to do that after biliary obstruction has been relieved, so you're not operating on a jaundiced patient. So operate if you can. If you can't, relieve the biliary obstruction first, and then deal with the gastric outlet obstruction, either with a duodenal stent or with a gastrojejunostomy.
Right. I think we have a question from one of our panelists here, Dr. Professor Duminda, the president of the Sri Lankan College. Duminda, you can ask the question. You put it on the chat box. Is that all right, Duminda? Are you there?
Yes, please proceed with the question. Yeah, you may. Yeah.
Okay, right. Duminda says that is PET scan useful before resection in patients with incidentally detected gallbladder cancer?
So from what I understand is this is a scenario where on pathology, the biopsy has shown that there is a gallbladder cancer. And before reoperation, do we do a PET CT?
You are right. That's
An-
the question.
And the answer in most of our experience in recent times is yes, we would do a PET CT for staging this patient because these patients have not been staged before this. And this seems to be the best way of staging these patients. Especially if on pathology, it appears that there is a node or cystic node which is available is positive, or it is T2 plus disease on pathology report, they certainly merit a PET CT scan prior to reoperation. And if PET CT shows evidence of disease, then no resurgery but chemotherapy.
Great. Thank you very much, panelists and speakers. Is there any question from any one of the panelists or people here? Dr. Praveen Suryavanshi, Dr. Santosh, Mr. Joe Abela, any questions from your side? Joe has written the role of EUS drainage, anatomical contingency or palliative.
Hi, can you hear me?
Yes, sir, we can.
Hi, first of all, thank you for having me here. Yes, question to my previous boss, Ewan.
I was never your boss, Joe. I was just a colleague.
Ewan, you made it very clear the way you go for the RCP and stenting, but we haven't heard much about EUS drainage, EUS and SAMS.
Yeah.
What is your experience with it? Is it just something that a gastroenterologist would go for, or do you use it at all?
Yeah, that's a really good question, Joe. As always, put me in the spot. So we've started doing EUS colidoco duodenostomies, but we do it in the patients in whom we've failed the ERCP. And the more that Colin and I have discussed this, we wonder if that's actually the right approach. And perhaps we should be going directly to an EUS biliary drainage. And there's a couple of reasons for that. Well, there's two reasons for and there's one reason against. The two reasons for EUS biliary drainage, so a small axis from D1 into the bile duct, the two reasons for are one, there's no risk of pancreatitis because you're not crossing the ampulla. And that's a really important one. And the second one is it should be easier if the duct's at least 10 millimeters because you're not trying to traverse a stricture to get in. So that's the two reasons for doing it. The one reason for not doing it is, and again, I've made this point in several talks I've given recently, you have to pick a procedure based on how well it fails, not on how well it succeeds. So for example, an ERCP, if you can't get in, it usually fails quite badly, quite well, I beg your pardon, in that you just have to go to PTC after that. If you do an EUS drainage, however, and it fails, and you get a stent misdeployment, then you end up with biliary peritonitis. So the short answer to all that is, I think we should be doing more EUS drainages. We still haven't quite worked out the exact group of patients, but there's no pancreatitis with it. You're not traversing tumour. And as long as you pick your patients safely in terms of comorbidity, it sounds like a good idea. I've done a few Whipples in patients in whom we've put in an EUS stent in advance, and it made, for what it's worth, no difference to the resection because the stent's actually contained within the specimen. Does that answer?
Yes, that's another
Yes,
perspective.
perfect.
Yeah.
Perfect. Thank you. Thank you.
Thanks, Joe. Thank you.
Any comments from President Dr. Praveen?
Yeah. Actually, I'd like to ask one question to Jan. In your practice, in how many patients without proper biopsy report you do major surgery like pancreatic duodenectomy?
Yeah, I think it's it's a reasonably common occurrence. So for the patients where we think they have, if there's a suspected periampullary malignancy and we have a negative brush and there's a mass to EUS, we usually have 2 shots at EUS with 2 different operators. Partly because it doubles your chance of getting the result, but also it means you've got 2 independent people who've looked at the EUS pictures and said, there's a mass there. So in the fit patient with all the right surrogates, an obstructive jaundice, big ducts, stricture, mass, if the ERC and 2 EUS are negative, then we would offer resection for that group of patients. And it's almost always a cancer. There are some exceptions, as long as you've done an EUS and you know it's not a stone. Occasionally CP, occasionally autoimmune, but usually by the time you get to that stage, it's usually a cancer.
Okay. Here in India, we get a lot of tropical, like pancreatitis, all that. So they present with big masses, and it's sometimes become very difficult to take decision. So, what do you have any suggestion for that? Any experience on that?
Yeah, in terms of discussing with the patient or just in terms of what?
Chronic pancreatitis, suspecting malignancy.
Yeah, so one of the unique factors about these patients are by the time you've got mass forming CP, you've quite often in our country anyway got comorbidity and lifestyle issues such as cigarette smoking and alcohol that have caused the CP that render you not a great surgical candidate anyway. For the patients who have hereditary chronic pancreatitis with mainly a mass in the head, I think it's perfectly reasonable to offer them resection, usually for pain plus or minus biliary or gastric outlet obstruction. So yeah, we've got some experience of that. And going back to your earlier point, I think one of the hardest things is trying to have a discussion with the patient where you offer a Whipple for what you think is a periampullary cancer and have no proof of that. It's a really difficult discussion. And usually I would have that discussion over 2 or 3 clinic visits and maybe even involve some of my colleagues so they're getting different perspectives on it. But it's rare you would take out a patient's pancreatic head where you thought there was a cancer and it's not.
Thank you.
Thank you. Dr. Santosh, would you like to?
Nothing.
Right. Thank you, Doc. Can I have the concluding remarks from, it was an excellent talk, and we're looking forward to the concluding remarks by the Vice President of the RCPSG, Mr. John Brendan.
Thank you, Probal. Ladies and gentlemen, as we draw this excellent session to a close, it gives me great pleasure to offer on behalf of both the Association of Surgeons of India and our college, the Royal College of Physicians and Surgeons of Glasgow, our sincere thanks to all who have contributed to the success of today's webinar, the 6th in our ongoing and enriching collaborative series. Our focus today on malignant obstruction of the biliary tree has been both timely and highly relevant, and we are deeply grateful to our 2 distinguished speakers, Professor Sikora and Mr. Dixon, for their insightful presentations and thoughtful contributions to the discussion. A warm thank you as well to our expert discussion panel, whose insights and contributions greatly enriched the conversation. I would also like to extend our appreciation to the President of the Association of Surgeons of India, Dr. Suryavanshi, as well as to Probal, the immediate past President of ASI, whose continuing leadership and support have been instrumental in sustaining and strengthening this important partnership between our organizations. Special thanks are due to the dedicated organizers from both ASI and our college, in particular the technical guru and IT expert, Mr. Avinit Kumar, Mrs. Jen Crozier, who's the Deputy Head of Education of our college, and also Mrs. Fiona Winter, who's Director of Education, whose hard work behind the scenes ensures the seamless delivery of each session in this series. I would also like to acknowledge the support of our college president, Professor Hania Tiba, and my fellow surgical vice president, Mr. John Scott, for their steadfast support of these joint educational initiatives. And most importantly, a heartfelt thank you to all members of the audience, because your presence, your engagement, and your commitment to continuous learning are what gives this series its true purpose and impact. As we conclude, we will look ahead with optimism and resolve, and may the collaboration between the Association of Surgeons of India and the Royal College of Physicians and Surgeons of Glasgow, and also our colleagues in surgical societies around the world, both in Asia and in Europe, continue to grow in strength and shared purpose, fostering shared knowledge, mutual respect, and excellence in surgical care. Thank you once again, and we look forward to welcoming you to the next session in this series. Thank you very much.
Thank you.
Thank you very much, and good night to all here in India, and to people in Scotland. Have a nice weekend. Thank you very much. Good night till we meet again. Thank you.
Thank you all.
Thank you
Goodbye.
very much. Good night. Thank you.
Thank you,
Bye
sir.
bye. Bye bye.